am Dr. Sanmoy Dutta, physician practicing in Kolkata, attached with Behala Balananda Brahmachari Hospital. Today I will discuss on latest update in hypertension. As per WHO, nearly 63% of total death in India are due to non-communicable disease, of which 27% are attributed to cardiovascular disease, which affect 45% in 40 to 69 age group. Raised blood pressure is among the most important risk factor for cardiovascular disease. Poorly controlled, it remains due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, prevalence has also gone up over the last 30 years to 30% in men and 32% in women, from 29% and 28% respectively. Despite that, nearly half of the population with hypertension are unaware of the condition. Additionally, 62% of men and more than 53% of women living with hypertension did not get any treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension has released 2020 Global Hypertension Practice Guideline. The inclusion of optimal and essential treatment paradigm attempts to address the issue that in resource poor setting, optimal care refers to evidence-based standard of care, and where essential standard refers to minimum standards of care to allow specification of essential standards of care for low resource setting. The AHA and AACC has released a scientific statement in 2021 offering new guidelines for management of stage 1 hypertension among patients with low atherosclerotic cardiovascular risk. Among low-risk adults with stage 1 hypertension, that is blood pressure from 130 to 139 by 80 to 89 mmHg mercury, management starts with non-pharmacologic therapy. If blood pressure remains uncontrolled at 3 to 6 months later, consider starting pharmacologic therapy. Acute respiratory distress syndrome, that is ARDS, is potentially fatal condition involving lung damage, and experts often associated with severe COVID-19 infection. A recent study which appears in the Journal of American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Lowering systolic blood pressure targets down to 110 to less than 130 mm of mercury range substantially reduce cardiovascular adverse event in the STEM randomized trial, affirming the sprint finding for an older Chinese population. Among some 8,500 patients aged from 60 to 80 years in China, intensive target trimmed 26% of the composite cardiovascular risk. Finding from now a second major trial supporting a lower target could unite the guidelines, which even among US professional societies range from thresholds of 130 to 150 mm of mercury. With regards to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, 2018 European Guidelines of the Management of Arterial Hypertension recommends that diagnosis of hypertension should not only be dependent on office blood pressure measurement, but also out of the office measurements such as ambulatory blood pressure measurement, home blood pressure monitoring, 24-hour and nighttime BP measurement were associated with greater risk of mortality and composite of cardiovascular artery. Thus, the may be considered as most relevant measurement for estimating cardiovascular risk. For every 20 to 10 mm of mercury increasement of blood pressure measures at right, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal blood pressure control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guideline recommends, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed dose combination of ACE inhibitor or angiotensin receptor blocker plus cardio calcium channel blocker or diuretic. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of a unknown carcinogen, namely NTMA, that is N-nitroso-dimethylamine, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by WHO, International Agency for Research on Cancer, to be carcinogenic in humans. If 1 lakh patients should have received NDMA contaminated valsartan every day for 6 years in highest dose, it could result in 22 additional liver cancer over the lifetime of this patient. The presence of NDMA in this drug could lead to 8 additional cancer cases in 1 lakh patient if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in rate of emergency department visit by 6%. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with significant reduction in endpoints, including death. The HYGEA chemotherapy trial tested whether nighttime therapy in comparison to usual on awakening hypertensive therapy exerts a favorable cardiovascular risk reduction. Largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced primary cardiovascular outcome. An ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. The reduction of cardiovascular events was significantly improved for nighttime treatment when compared with awakening treatment. Thank you for your participation.